access program, which started in 2006 but ended in 2009, it later became the MCHIP program. But essentially, the access program is a program funded by USAID to increase access of women and communities to quality maternal newborn care as well as family planning services in northern Nigeria. And we have a reason for being in northern Nigeria. Populations in northern Nigeria are more prone to high parity, large numbers of children. They are less prone to use of family planning to space their children. And then they have higher maternal mortality ratios, neonatal mortality ratios, that is number of babies that die within 1 month. They have higher infant mortality. So all of those parameters are worse in northwest Nigeria than they are in the south. Well, essentially, when we were invited in 2006 to domesticate this global access program, the first thing we did was to do what we call a baseline survey. And a baseline survey that looked at health-seeking behavior in our communities, as well as service statistics in the facilities within the local governments where we're working. The intervention that we designed is called the household to hospital continuum of care. And this meant that we were interacting with pregnant women and their families at home, educating them about danger signs in pregnancy, danger signs during childbirth, danger signs after childbirth, and also even danger signs in their newborn. We were therefore trying to influence their health-seeking behavior. We had a number of strategies for addressing this at home. Then we thereafter worked in the primary healthcare facilities, because primary healthcare facilities are the first port of call for most pregnant women. So we were strengthening the primary healthcare facilities to be more effective, training staff in the facilities, donating equipment, renovating some of them, and giving them materials that they could use, and helping them to be quality of care conscious. And then finally, we also worked at the general hospitals, because there are some complications that cannot be managed at the primary healthcare level. So we worked at the general hospitals to renovate some of them, to seek, to donate some equipment like cesarean section kits, and also to train them, the staff, on how to use it. And above all, to also collect data, because you must be able to show the effect of the work that you're doing. So we needed to institute a data collection system that will allow us to track progress over time. So we are seeing progress, but we need to sustain these efforts, and we need to scale this up globally within the country to all the 36 states for us to really see the full benefit of these very simple interventions.